Now, let's move to the second STD, gonorrhea. Gonorrhea results in urethritis. So, the patient usually presents with frequency, urgency, burning dysuria. Frequency, urgency, burning dysuria. Well, this could be cystitis. How can we be sure that it is urethritis and not cystitis? When it is urethritis, you should have a discharge. A discharge. So the key word here is going to be a discharge. When you have a discharge, even without frequency, urgency, burning dysuria, it's going to be urethritis. So urethral discharge, vaginal discharge. This is gonorrhea. This is urethritis due to gonorrhea. So frequency, urgency, burning dysuria plus discharge. And the diagnosis of gonorrhea is now very easy. You do not have to have urethral swab. You can just take a urine sample from a male or a self-taken sample from a female. You don't need to do this speculum insertion. It's going to be painful, or insertion of some instrument to get urethral swab. Just a urine, mid-urine sample for a male or a self-induced swab in a female is enough to diagnose, to find this intracellular gram-negative diplococci, which are the Neisseria gonorrhoeae. But the most sensitive test for gonorrhea is the nucleic acid amplification test. And now the sample, as I said, for this test is voided urine for men and self-administered swab for women. Voided urine or self-administered swab. The diagnosis of gonorrhea is very easy now. Gonorrhea infection can be disseminated. It's not just confined to the genital region. It can result in polyarthritis. So whenever you have gonorrhea, you can have polyarthritic manifestations, you can have petechial rash, and you can have tenosynovitis. Three important criteria for disseminated gonorrhea: polyarthritis, petechial rash, and tenosynovitis. When it comes to treatment, we always treat gonorrhea and chlamydia together because they tend to happen together, they tend to produce the same kind of symptoms, and we should treat both of them together. So whenever a patient presents with discharge, this patient needs one gonorrhea drug and one chlamydia drug. One gonorrhea drug, the best is ceftriaxone intramuscular. And if the patient is kind of reluctant to take a shot, then we can give them cefixim. Cefixim is the cephalosporin, is the oral cephalosporin for gonorrhea. One gonorrhea drug. What is the one chlamydia drug? Azithromycin or doxycycline. For pregnant patients, ceftriaxone intramuscular is still safe, azithromycin is still safe. So treatment of gonorrhea, ceftriaxone; treatment of chlamydia, azithromycin. Our case study for gonorrhea. The key features here: a 17-year-old female junior high school student presenting with frequent urination, urgency, severe urethral burning during urination. What's this? Frequency, urgency, burning dysuria. It could be cystitis, it could be urethritis. But she has abnormal yellow, thick vaginal discharge. We have discharge here. Then it's gonna be what? Urethritis. We have to think of gonorrhea and chlamydia. Mild anal itching. Recent history of unprotected sex. So question 4. The single most important risk factor in this case study was this recent unprotected sex with an individual who was infected with gonococcus, and this resulted in the disease. Question 5. What are the two most definitive signs of gonorrhea in this patient? The positive PCR test and the positive PCR of urine specimen for Neisseria gonorrhea. So what's your diagnosis for this patient? This patient has urethritis, cervicitis. Urethritis will result in urethral discharge, cervicitis will result in vaginal discharge, and also proctitis as evidenced by the perianal itching due to infections with Neisseria gonorrhoeae and Chlamydia trachomatis. Remember, always the Neisseria, the gonorrhea infection and chlamydia infection, they go hand in hand. So the three blood test findings that are consistent with the diagnosis of gonococcal infection in this patient: elevated white blood cell counts. This suggests infection. Elevated number of band cells, immature white blood cell count, because your bone marrow is now in a hurry. It is rushed to produce more white blood cells to fight the infection, and sometimes white blood cells are released to your circulation while they are still immature, and we call them the band cells. And the type of white blood cells that is usually more elevated than the others is the neutrophils. So we get in the differential elevated neutrophils. The clinical evidence that supports or excludes a diagnosis of disseminated gonococcal infection. Remember, whenever you have a gonococcal infection, you need to search for, in order to confirm or exclude, systemic or disseminated gonococcal infection. So there was no clinical evidence for meningitis, no clinical evidence for gonococcal endocarditis, no joint affection, and the absence of fever will exclude kind of the systemic manifestations, and the patient denied having any chills, and there was no skin rashes. Remember, petechial rash is one of the disseminated gonococcal manifestations.